So next we have Dr. Deborah Cohen. She's a pediatric hematologist. She's also the director of the Transition Care Program, and she will also be the speaker for the transition session tomorrow. She conducts sickle cell disease telemedicine clinic at the Children's Hospital of Pittsburgh. So please welcome Dr. Deborah Cohen.
And thank you to NIMAC for inviting me here today to speak on telemedicine. This is a more clinical approach, an individualized institution at the Children's Hospital of Pittsburgh of UPMC. I have nothing to disclose. So the definition of telemedicine is one of our objectives, the 4 key elements and also benefits of telemedicine for the sickle cell patient population in pediatrics. So we've been talking a bit about bridging the gaps, and Dr. Watson mentioned telemedicine, telehealth this morning in our bridging of the gap and reaching out for funding. So for those of you who are not aware, the lovely city of Pittsburgh, Pennsylvania is the city of bridges in the world. We have more bridges than anyone else and overshot Venice by 4. So I think it's a perfect place to bridge the gap for our sickle cell patients for their healthcare accessibility. So what is telemedicine? And we've heard a number of definitions. It is a number of different types of approach to a telehealth platform. So it can be teleeducation, it can be teleconsultation, it can be telepractice, or teleresearch. And all of those are telehealth. So the literature can mix and match those, and I just want to be clear on our definition, which is a teleconsultation. So my definition comes from the World Health Organization, and it's pretty much what we've heard from HRSA as well. And this is it. The delivery of healthcare services where distance is a critical factor, as it is for our patients, by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of diseases and injuries, research and evaluation, and for the continuing education of healthcare providers, all in the interests of advancing the health of individuals and their communities. So that's a very nice clinician definition. Advances in technology, changes in reimbursement practices for telemedicine services have made it an attractive solution for extending the research of subspecialist care to our patients with sickle cell disease. If you do not change direction, you may end up where you are heading. And sometimes that's not where we want to go. So we need to keep up with the changes not only in monies allocation and grant direction, but also certainly, most importantly, for our patients' best care. So telemedicine in its modern form began in the 60s, and it was in large part driven by the military and space technology sectors, as many things are. The term was coined in the 70s, and it literally means healing at a distance. So that's very applicable for us. It signifies the use of ICT, or information and communication technologies, to improve patient outcomes by increasing access to care and to medical information. There are 2 types for my purposes. The timing of the information transmitted and the interaction between the individuals involved helps to define our telemedicine program. So it can be asynchronous or store and forward. This can apply to an email for a second opinion, for example, where you have pre-recorded data exchange between 2 or more individuals at different times, so your consult goes out not at the same moment as you receive it, versus what we do, which is synchronous or real-time, where we simultaneously present for immediate exchange of information. The interaction can be health professional to health professional, it can be health professional to patient, and the information can be transmitted using a variety of media, which in and of itself is growing and decreasing in cost. So there are 4 key elements. It provides clinical support. It overcomes geographical barriers, connecting users who are not in the same physical space, improves health outcomes, very important piece, and involves the use of various types of ICT. So in the United States, sickle cell disease disproportionately affects minorities and disadvantaged populations. This leads to significant problems with access to and delivery of comprehensive medical care. The lack of access to care impacts whether or not our patients are able to receive hydroxyurea, which is the only disease-modifying therapy that is available today for patients with sickle cell disease, other than a transplant. In 1995, just to bring you up to speed on hydroxyurea, if this is something you're not familiar with, there was a well-done randomized double-blinded placebo-controlled study in adult patients with sickle cell anemia. And it demonstrated hydroxyurea, when given to severely symptomatic adults, resulted in a 44% reduction in pain crises. And if you yourself have sickle cell or know someone who does, this is a very debilitating and life-changing event that happens over and over and over. And so having something that can make a change in that is very important to our patients. It also gave us a 45% reduction in acute chest episodes in that study in adults. And acute chest is something that will take the life of a sickle cell patient. 30% reduction in need for acute transfusion. That has a lot of benefits, as blood supply is not always available, though the infection rate, transmission of infection rate has decreased over time. It's still not zero. So that's important for our patients. But it requires close follow-up. So those are the things, the most important things that were noted. So then we said, well, what about us? So they did the Baby Hug study, and that was a phase 3 study done in 2003 with 9 to 18-month-old patients. So that too was a good study, randomized, double-blinded, placebo-controlled, for patients with hemoglobin SS and S-beta thal 0. That is the most severe form of sickle cell disease that we see. However, I want to just note that patients with other forms of sickle cell disease can also undergo many of the same type problems, and they can be very seriously affected. So they had 193 subjects, and what did we learn from that study? Decreased rate of initial and recurrent episodes in pain, similar to the adult study. Twofold lower rate and less likely to have multiple episodes. So for sickle cell patients to receive this information, that's exciting for our kids. Dactylitis, which is a symptom not seen in adults, but in children, they have swelling of their hands and their feet as infants and toddlers, which does cause pain, but not always. And there was a 5.4-fold lower rate, and they were less likely to have multiple episodes as well. So here's the acute chest piece, very important for mortality. Early acute chest can be associated with recurrent episodes and pulmonary disease and mortality even later in life. And there was a 3.5-fold lower rate and a lower rate of recurrence. Transfusions, 34% in the placebo group and only 21% in the hydroxyurea group of children. So the results speak to the same language as the adult study. Infants taking hydroxyurea had significantly fewer acute sickle cell-related complications. And as we're learning, now that the study has been long enough for the data to mature, they are doing better as adults. Their growth and development is more normal, and their lifespan is longer. So we're very excited about that, and the telemedicine program is really focused on being able to offer that to patients that don't live in our city or near our city, to be able to come into clinic for that very close follow-up that was previously mentioned. So we did a distance strategy project with the partnership with NIMAC, and the overarching goal was to improve the access to care and as a result, positively impact outcomes for children with sickle cell disease through the integration of telemedicine into our existing network of healthcare for our patients, which sounds somewhat like the WHO definition. But it was also to make available hydroxyurea to all patients who are eligible. So Children's Hospital is the sole provider of comprehensive care for our pediatric patients with sickle cell disease or a trait in the 32-county region of Western PA since the inception of newborn screening in Pennsylvania for sickle cell disease in 1992. So here we are. You can see all of the red dots are where our patients live, and we currently have 218 pediatric patients with sickle cell disease. So here's an area, Erie, and here's another, Johnstown, both of which are not really reasonably within a distance that a patient can travel with the family monthly for hydroxyurea follow-up. So Erie is 150 miles, so depending on how you drive, that's probably 2.5 or greater hours. And Johnstown is 75 miles, so depending on traffic, which in Pittsburgh can be difficult, is a good 2 hours in rush hour. So in collaboration with our telehealth team as well as NIMAC, we established virtual clinics at the CHP telemedicine satellite centers. They are located in fully functional outpatient clinics, and they are staffed with reception staff for check-in, and also with medical assistants who have undergone additional training in operating telemedicine equipment. So here we are. This is on your right, the actual room in which we reside, and there are 2 of those at Children's. And then on the left is the Polycom system on the cart, which resides in the clinic, outpatient clinic room, wherever the clinic may be. So for us, that's Erie and Johnstown. So this is a chart to say, if you look, the red piece of the pie is those that are able to take hydroxyurea and have elected to do so. And the maroon piece of the pie are those that are not taking hydroxyurea for various reasons. So we looked at our Children's Hospital patients who are on the left, and you have 42% that are taking hydroxyurea. But if you look on the right, the telehealth patient number is 74%. So very different. Now, it's a smaller number, so we have to take that into consideration. And it's also, I like to think, since it is part of our focus of telemedicine, a result of that. So when patients come to clinic, there's a lot of things that we talk about. But when they come to telehealth clinic, that's first and foremost on the list. We don't forget it, we don't not think about it, we don't miss talking about it, and so it's helpful. Now that is not to say that we don't see patients in the telehealth clinic that aren't on hydroxyurea, but it is a focus, and I think that's important, and it doesn't get lost within the visit. So if you look at our Erie patients, of which there, through this time period, have been 17 to 21, not years, but number, again, the red is the hydroxyurea, the patients taking their hydroxyurea, and on the left, you have your patients 41% taking, but then if you look at the telehealth patients from Erie, there are 78%. So again, is that likely due to focus? It very well may be in part. So the Erie patients on the left are only seen in the outpatient clinic twice a year. The Erie patients on the right in the telehealth clinic are able to be seen every month, all year long. So this is a little bit small, but if you look on the left axis, that's a question number from the survey. And across the bottom are number of responses. This was a rating scale of 1 to 5, used for questions that were actually related to aspects of the patient experience, meaning was the audio, were you able to be understood? Was the video, were you able to see the doctor? And so very specific questions. And as you can see, though there are a few small green and blue, yellow and red on the left, the overwhelming majority of patients felt that this service for their medical needs was excellent. And then this is other questions using a nominal scale on the survey related to ease of access, seeking out telehealth going forward, which I thought was an interesting number if we compare it to what Beth had mentioned earlier, and then recommendation to others. So it's a yes, 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 I think, across the board for a very high percentage. So it's working, is what that tells us for our patients. So it is allowing us to improve delivery of healthcare services. Outcomes being hydroxyurea can be offered to all of our patients despite the distance from home to the Central Pediatric Sickle Cell Care Facility. So our patients in Erie may never come to Pittsburgh. So we can see them on the telehealth system, and we go twice a year. Cost effectiveness, parents are not missing as much work. They are not having to take off an entire day. There is a decreased travel expense in relation to that, and we also have a community-based organization that is very helpful in assisting our families and bringing patients to the center if need be. There's an enhancement in communication without a doubt. There is a telegenetic opportunity in using the telehealth, and that is something that I'm going to speak about shortly. And then there's an educational opportunity as well. As we mentioned earlier, telehealth can be teleeducation. So we, in conjunction with NIMAC, created a telehealth workshop. So the telehealth workshop was from September of 2015 to April of 2016. And it was how to start or build your own telemedicine program for pediatric patients with sickle cell disease. And similarly to what Alyssa was talking about, it's very difficult to reach the people that need to be reached, and it's very time-consuming. So I would have liked to have done more, but we have a foundation. So the agenda for this workshop was a working lunch, current status of the telehealth of each visiting institution, and a telehealth presentation in regards to pediatric patients and sickle cell disease. The telehealth project plan, which they received, the how-to, had meeting the milestones or a schedule to follow, a flow chart, very important, required documentation for telehealth, working process flow diagram, training checklist, you can't do telehealth without training the staff on all ends, telemedicine technology and equipment available given by our IT department, who are, for me, a necessity, as I am not as savvy as some of you may be. And then there was an IT question and answer session, again for the same reason. So ask the people that know. Telehealth session with the patient, and hands-on equipment demonstration, which they enjoyed. And then a group discussion with our telehealth director, IT, and the participants with myself. So challenges: lack of time, lack of colleague participation, lack of technical resources or infrastructure, difficulty with licensing, and that was more in relation to extended providers, and difficulty with reimbursement or billing, which is something everyone faces. So while this was a small number, these were the responses that we received on the survey following the workshop. Benefits: improved accessibility to care, 86%. Reduced wait time. For us, there is a reduced wait time, but I think until you do it, it's hard to understand how to get the flow to work for you. Reduced costs. Improved communication with patients and families, so 71% believe that would be the case. And improved patient satisfaction. Increasing the workforce capacity. Overall, the program was excellent, 86%. And then the workshop participants thought the information presented would be very helpful in 100% of the cases. So I think successful in its inception. It provides an opportunity for us in the future for genetic counseling with families who have an infant diagnosed with hemoglobinopathy trait detected on newborn screen. And that is going to begin for us this year in November, about which we're excited. It may also provide an opportunity to teach families about sickle cell disease and to educate adults who are unaware of their disease status. So I just want to mention that in the past 3 months, we have had 2 trait patients on newborn screen present to us where we have diagnosed a parent with sickle cell disease that they were unaware of. So it is an avenue and a means to reach out for parents who were likely not a part of the newborn screen process unless they're young, because it didn't really begin until the early 90s or mid-90s for most states. So what does that mean? Well, in 2012, nearly half of the hospitals reported having active telemedicine programs. The hospitals that joined us for our workshop, none of them had utilized telemedicine for our patient population. Advances in telehealth services include the gap service coverage, so we've started to fill in those overnight scenarios for clinical care, urgent service coverage, mandated services, so how do we reach those that we can't reach, for example, in the juvenile detention centers? And its widespread adoption is going to be influenced by a number of things. Implementation of key provisions of the Patient Protection and Affordable Care Act, technologic advances, which are coming fast and furious, including the ability to use your laptop with HIPAA protection and good audio and visual function, as well as good equipment where you can listen to the patient's heart and do a true exam without feeling as if you're missing something. Growing patient demand. They don't want to travel and they can't get in. And so they say, you can see me in 3 days, I'm there. Telemedicine's greatest strength lies in its ability to overcome the barriers of distance and time to reach our medically underserved populations. References for that piece, and then acknowledgements. Certainly I'd like to thank NIMAC. Our telemedicine center is quite amazing, and our IT folks are very helpful. And then my staff, the community outreach program, as I mentioned, which is incredibly helpful. The physician who began this work, Dr. Krishnamurti and his staff, and our patients. Thank you.